Let me introduce Dr. Wozniak. Dr. Wozniak is really amazing. And in terms of her willingness not only to have taken the risk way back when to say that kids may actually have bipolar disorder, but also to treat a lot of kids who really are struggling. So her work is informed by her direct clinical care, by all of her research, and her focus on trying to help people with pediatric bipolar disorder and their family. Dr. Wozniak, thanks for being here.
Thank you.
So with that, monitors are up there.
And the clock.
Yeah, okay, great, thank you.
And my slides will come up. Thank you so much for that introduction. Thank you all for coming today to learn more and hear more about the work that we all do. I love listening to Andy and hearing that our brains are using so much energy, so while we're all sitting here, we're burning a lot of calories if we're thinking really hard, so that's good to know too. This is just a roadmap of what I'm going to go through today, and I have about a half an hour to speak. I've got too many slides, and so we'll see what we can get through to the best of my capacity here. What I'm going to talk to you about bipolar disorder that onsets in the pediatric years, childhood and adolescence. And it's a morbid illness. It affects a significant minority of young children, certainly not a majority, but maybe we think about 1% to 3%, but it's still millions of children. And for some people, it's too many diagnoses of bipolar disorder, and there's backlash regarding it. But it's now in the differential diagnosis for moody children. I'll give you an overview of our diagnostic description, how we might think about identifying it in youth, and also some of the data that we have about persistence, familiality, establishing the validity of this diagnosis, treatment, and then a bit about the biology and biomarkers that we have available. So I love this slide, and it's really my advertisement for why every psychiatrist should be trained in child and adolescent psychiatry, because most of the major psychiatric disorders that we treat start in childhood or adolescence. In fact, 20 to 25% of adolescents already have a psychiatric disorder, and I'm not talking about small phobias or minor issues. This is with severe impairment. So I think that as a society, as a medical profession, we're sticking our heads in the sand by dismissing this as childhood things that are minor and of no consequence. In fact, we know that these things lead to the problems that adults come to in the adult clinic. And as Andy was pointing out, our brains are so extraordinarily complex. The brain development involves growth and pruning of not just billions, hundreds of billions of neurons from the very point of conception and birth, and as our nervous system is developing. And so it's not a surprise, is it, that something can go wrong with the system from the very get-go. People will sometimes say, how could a child have a serious disorder that severe? Well, the fact of the matter is heart, lungs, kidneys, actually those are rather simpler organs, and most pediatric practices are full of kids who are healthy in that way. But the brain is far more complex, so I would say it's not at all surprising that things may go wrong. And then in terms of bipolar disorder, we know that about 25% of adult cases onset prior to the age of 12. These are in the prepubertal years. And then we can even start talking more about preschoolers if we really want to talk about early intervention, because about 75% of that group, parents will describe onset in the preschool years of life. So work from our group that Dr. Nirenberg so kindly referenced, has really helped usher in this paradigm shift in which when we see children who have mood problems, we think about bipolar disorder as part of the differential diagnosis. And I guess I'll just amend one thing he said, is that before we started doing our work in the mid-1990s or publishing it, it was hitherto thought, or it was very little thought there would be bipolar disorder in children, but parents knew things were wrong with their children well before that. Clinicians who see active clinical practices full of children with problems, they knew that something was wrong. And so when we published our work saying that could this be bipolar disorder, light went off for those individuals. I'd say the biggest pushback came from more ivory tower researcher colleagues who had been doing research in children for years and had missed this. And how do we make the diagnosis of bipolar disorder? Well, it means you've ever had an episode of mania. And we use the same criteria for children as we do for adults in our DSM manual. And here it's got two parts. The first part has to do with an abnormal mood state that's either elevated and expansive or highly irritable. And in our recent edition of the DSM, we added persistently goal-directed high-energy activity, which interestingly kind of overlaps pretty well with this idea that we see children who are very hyperactive, and this hyperactivity often has this quality of extreme high energy, goal-directed, highly focused, often distracted, but always moving around. And then the ancillary symptoms, there's 7 of them that go along with this diagnosis, and the ones I've highlighted in red are the ones that overlap also with attention deficit hyperactivity disorder. ADHD is like a bread and butter diagnosis in child psychiatry. It probably affects maybe 10% of children and adolescents, maybe more if you start to think of spectrum cases of it. It persists into adult years. So it's a diagnosis we know quite well and had been well established by the time we started doing our work. Because of these overlapping symptoms and the overlap in these diagnoses, most child and adolescent psychiatrists think of pediatric bipolar disorder as like a subset of our ADHD population. The adult psychiatrists think of this group as, it's a subset of the adult population with early onset and cognitive problems. So let me keep moving on. Talkative pressured speech is one of my favorites, and I'm going to use that now to get through all my slides. So what did we learn about mania in the children from the studies we did? I'll just cut to the chase for you. The major mood disorder chief complaint of the parents was severe irritability rather than euphoria. It wasn't that the children weren't goofy, giddy, hyper, silly, laughing fits, life of the party, joking all the time in a disruptive and problematic way from time to time. That's just not the biggest problem. A much bigger problem were the states of irritability. Angry, defiant, explosive, alienating others with these angry moods. We also noticed that the children mostly had mixed states. So if you were looking for bipolar disorder, that sometimes I call this celebrity bipolar disorder, where you have a period of very high euphoria and you get a lot accomplished and you're very talkative and provocative and you don't sleep and you're dressed in bright clothing, and then you go into a melancholy and you stay in bed and you think about suicide and you don't feel well, you can't function at all, and then you come out of it and you go on your book tour or you do your one-woman show, like Carrie Fisher would describe her bipolar disorder. That's not the kind of bipolar disorder we were seeing. And in fact, it's not the most common type of bipolar disorder in the adult clinics either. People with bipolar disorder often have these mixed states where depression and mania overlap in time, waxing and waning and in and out of these different mood cycles of mania, depression, mixed state, in a way that looks more chronic and persistent than defined into discrete, nice, neat episodes of suddenly a switch goes off. The children were seldom well, and not only due to these mixed states and mood waxing and waning, but also high rates of co-occurring other conditions, which I'll talk about. And almost all of them had what in Boston we call wicked bad ADHD. They met criteria with all the symptoms, yes, of the different, 18 symptoms of ADHD. So they were often children who would come to me with that diagnosis ahead of time. So while most young children with bipolar disorder, these are the underage 12 group, also have comorbid ADHD, there are plenty of ADHD kids who don't have significant mood disturbance or have minor states of depression that don't meet this threshold for mood disorder or bipolar disorder. But there's very distinct difference between the children who have ADHD without a mood disorder and children who have ADHD plus bipolar disorder. So it was part of our early work to say, this is not just moody ADHD. These children are really something different. Their rates of co-occurring conditions are just much, much higher. When psychosis was present in our clinic, it wasn't in children who had non-mood disordered ADHD. It's in the children who had the mood symptoms of mania and depression. Conduct disorder, which is not a minor misbehavior problem. These are pre-criminals. This is a matter for public health. If you were to say to me, if only we could catch these criminals when they were children. Well, yeah. We've got them, we know who these conduct disordered kids, we know their path in life, that they get involved in the criminal justice system very early. So there's an opportunity to intervene if NIH would agree. And then anxiety disorders. It's often not thought that an individual that's so disinhibited and wild and disruptive might be scared, inhibited, fearful, self-conscious. But that's exactly what they are. Sometimes I'd say to parents, when your child's behaving like this, go to another room, walk out of the house, and they'd be like, oh no, it would throw them into a panic to be left alone. The anxiety co-occurs with this wild mood disinhibition. Functioning very poor. At the average age of 8 was this data, 21% of the kids who came to us had already been psychiatrically hospitalized, and that's usually for aggressive behaviors or suicidal behaviors towards themselves as well. So pediatric bipolar disorder co-occurs, overlaps with ADHD, but it requires significant mood symptoms to diagnose. And the severe mood dysregulation is generally with irritability. This combined condition we see throughout the lifespan up into the adult years too. So in these larger studies of adults, the National Epidemiologic Survey, the National Comorbidity Survey, of the percentage of adults who have ADHD, bipolar disorder is overrepresented. It's a combined condition. It's giving us a clue as to some of the genetics of this disorder. What are the different subtypes? When we say bipolar disorder, by the way, we call it that like it's just one big bucket of a problem. But in fact, there's probably different types of bipolar disorder within it, that it's not just one disorder. And one of the pieces of distinction could be pediatric onset, comorbidity with ADHD. There might be a clue there to the pathophysiology of that piece of bipolar disorder that could be different from the others. Maybe it's one of the reasons that when we do these studies searching for genes and brain scans, if we just throw all the bipolar individuals into that study, we may not see meaningful distinctions because there are different subgroups within the bipolar population. So this pediatric onset population may be distinctly worth scientific study and give us greater clues as to how to treat all individuals with bipolar disorder. So I just want to give you a sense of the scope of the problem. In my practice, it's almost 100% of the kids and teenagers who have this disorder. Epidemiologically, internationally, nationally, the rate is somewhere in the range of 1 to 3%. It still represents millions of children and adolescents. Well, what about this backlash I mentioned? In our last edition of our diagnostic manual, a new disorder was created. And if you read online, the committees for the DSM literally had the task of reducing the number of pediatric bipolar diagnoses because they were concerned that it was stigmatizing, because they were concerned that maybe it was too serious a diagnosis to give to such young people, because they were concerned that it was going to lead to certain medications being used inappropriately. Meanwhile, the adult committees were saying, we're missing bipolar disorder. We need to make it easier. We need to make mixed states an easier diagnosis to make so that people aren't inappropriately treated with antidepressants when what they need are mood stabilizers. So it's a kind of unusual mismatch. And I think I'd put it into the category of the difficulty of a paradigm shift. People become nervous and scared when you tell them that the earth is not flat, that it's round. And so we lived through this upset period. So now we have DMDD, disruptive mood dysregulation disorder. It's not a particularly useful diagnosis, and if you look at the whole criteria, I'd say that it's really, as you read it, either kids who have major depressive disorder, or it's a different word that people want to use for bipolar disorder when they're afraid to say bipolar disorder. Technically speaking, the exclusionary criteria includes so many manic symptoms that you shouldn't apply it to somebody who has bipolar disorder. And yet, does it add anything? Because children who are depressed or irritable looks a lot like the defiant children with depression. In the end, it hasn't led to any novel treatment interventions, and in fact, depending on how it's used, you're either getting treated for depression or bipolar disorder. But it does speak to the fact that when someone has a serious mood disorder, we just have these two buckets of diagnoses and two kind of treatment algorithm sets, when what we really need is something much more personalized, that there are individuals who have depression with a few manic traits, and that's why we started to use the term bipolar spectrum, and they may need a different set of treatments than the individuals who have just depression. Well, and do we have a blood test or a brain scan or some other very specific test that you can do, paper and pencil, that will absolutely make this diagnosis? I'm sorry, I wish we did. And when people say, give me that scientific test for bipolar disorder, I'm always saying, I'm sorry to disappoint you, but I'm going to ask a series of questions and talk to you and your family and all the rest, and then I'm going to tell you, based on what I know, whether you best fit into this diagnostic category. It's a clinical diagnosis. That's not to discount it. I mean, those of us who make these diagnoses have years of specialized training. Child and adolescent psychiatrists spend a highly focused time trying to understand the distinction between typical development and atypical development, and figuring out how to best categorize that given our system so that we could lead people to the right treatments. But when you have a complicated diagnosis, you can look at a number of things. Symptom profile is one of them. And here's 2 different studies that really show kind of almost fingerprint pattern of the type of symptoms that present in kids. Again, this is the under age 12 group. And the age of onset of their bipolar disorder, by the way, was age 4. So these are kids who, when they come to me at age 8, have already had 50% of their life in an emotionally dysregulated state. So that if we're really committed to early intervention, we need preschooler studies. I need to know not that 8-year-olds often had a difficult preschool life, but of all the dysregulated preschoolers, which of them need our focused attention, close follow-up, and maybe intervention possibly with medications, but I have a particular interest now in complementary and alternative treatments, things you can do that are safe and healthy and good for you that might help set your brain on a better trajectory. And here's the point about the irritability. Most of the parents, when we asked them, have you had 7 days or longer of a severely impairing mood state that was euphoric? About 30% of the parents said, yeah, my child has had that. But when we asked, have you had 7 or more days of a severely impairing mood state that's highly irritable, above and beyond just grouchy, cranky, difficult days, 92% of the parents endorsed that. And that's what they were coming into the office for. And so what about this irritability? The story of pediatric bipolar disorder in many ways is also a story of irritability and how we understand it. It's such a common symptom just in regular life and throughout all of the psychopathology or psychiatric syndromes that we diagnose. And yet, we tend to discount it. And when I started doing my training, if a child was irritable, it was like, of course they are. But what we came to discover with the bipolar kids is that there's different types of irritability. And the type of irritability that the parents were endorsing for mania was a very severe form that was extremely disruptive and impairing. It was persistent and often violent. So the children would have grouchy, cranky, whiny, complaining, difficult to please moods, but it would often turn into outbursts, threatening, attacking behavior towards others, family members in particular. It usually starts within the home. I usually say, if this is a disorder of your emotional centers of your brain, it's really only the people who emotionally matter to you that are going to be the biggest triggers. Strangers, teachers, friends, probably not as provoking to this problem. But in addition, these are individuals who also have some level of insight as the disorder is developing, that controlling themselves in these outside settings is in their best interest because of the consequences that can ensue. But at home, parents are seeing outrageous destructive explosions. Sometimes I used to say, is there anything destroyed? Now I'll say, how much spackle do you use every week for the holes in the walls? Because it's that type of rage. These are little children. Have you ever tried to put a hole in a wall? I've tried it, and I hear about these kids kicking the wall, punching, banging themselves, their heads on the wall, to the point that there's destruction. So this is an internal rage that's, sometimes I say it's like rocket fuel. It's just so intense and alarming to see, but it becomes the new normal for these families. They're often frequent, they're often daily, they're sometimes more than daily, and they can be long-lasting. These are not just a few 5 or 10 minutes of a bit of a explosive irritability, short-temperedness. This is something that can just linger on and go on in a way that's shell-shocking. Now, do people have smaller outbursts, and what do we do with that? Well, the disorder can unfold. Like I said, it's not like a switch goes off and one day you're having 60-minute outbursts every hour. Children can be developing. We see them as something that's, moving in front of us. It's a moving target. And so it's the goal of the child and adolescent psychiatrist to see what direction is this heading and who do I need to spend more attention to. So for example, what we call subthreshold or subsyndromal cases are now something of considerable interest to us, not only because we realize that we may be catching something that's worsening, but also in and of itself, these, like my boss says, these kids don't read the book. They don't know they have to have so many symptoms for so many days. These subsyndromal states, in and of themselves, are very highly impairing. Just a few drops of this can be devastating to your life and your functioning. This slide is meant to represent my concept of the chronicity. It's not that the kids aren't cycling, mania up and down, depression up and down, but because the mixed states are coming and going and the mania is coming and going, and in between you have ADHD and anxiety, oppositional defiant features, you've got a child who almost never seems well. So it's our job to tease this out. In what way are they not well and how can we intervene? The mixed presentations are more common than these kind of separate mania, biphasic, what we call presentations. And one of the early studies we did when we were trying to distinguish this from other disorders in childhood, especially ADHD, is we said, you know, if these kids really have a form of bipolar disorder, they're likely to have higher rates of family history of bipolar disorder because we know already at this point that bipolar disorder has genetic underpinnings. In fact, I think that it's not as well known by the general public that the disorders that we treat in psychiatry are as genetically linked as things like breast cancer and heart disease. Every woman knows if you have a family history of breast cancer, you're worried and you're getting your mammograms. People don't tend to realize that when you have a family history of a severe psychiatric illness, that it means that any individual who's related is at higher risk for that illness. But in fact, we know that there's genetic. Can I tell you which genes they are? There's many. And it's like getting dealt a deck of 1 billion cards. Some of them are good cards, protective. Some of them are the bad cards, more likely to make you sick. The balance of it, plus your environment, comes into whether you have a disorder or not. Someday, though, hopefully we'll be able to look at the deck of cards and see where the risk genes are from the earliest years of life, which could give us really a good shot at prevention. Well, anyway, this work, one slide, represents about, I don't know, a decade or more of work for me and for my research staff. But we compared children with bipolar disorder who we had diagnosed to the children who had ADHD without mood disorder at all. And then we asked the question in their first degree relatives, what disorders did we see? And you can see from this slide, that purple bar, that the individuals, children with bipolar disorder had much higher rates of bipolar disorder in first degree relatives. It's an external validator to the fact that we were barking up the right tree in diagnosing these children as having bipolar disorder, that we don't need DMDD or some other name for them. And interestingly, even the children who had subthreshold bipolar disorder had similar rates of familiality. Again, raising our concern about children who have a smattering of these symptoms, subthreshold symptoms. Adults as well. And the disorder is persistent. If we follow these children out 4 years, 5 years, 6 years, we see that most of them persist with bipolar type 1 episodes. And the way we define remission in this study was we wanted to see individuals who had a full year free of their mood symptoms. We decided that that was actually a clinically meaningful remission. If the study is looking at a week or a month, in your life and in your kid's life, that's not a remission. That's just a breather. So we were looking for a long period of remission without the need for any medication treatment, and only about 6% of those kids got to that point. This is consistent with other longitudinal studies from other sites. And despite whatever controversy there's been about this disorder, there's actually way more agreement across our sites, Pittsburgh and St. Louis and other places, New York, than there is disagreement. We continue to look at the 5-year follow-up, the 6-year follow-up, and we see the same thing. We also decided to define not just remission from the full syndrome mania, because that's also not clinically meaningful. If you're persisting with subthreshold states of mania or depression, it's highly impairing. So we measured that as well. And so we see that there's just a very highly persistent state to this disorder. And we know that when we only have longitudinal studies so far that have gone so far, up to early adulthood perhaps. But when we go to the adult clinics, and our colleagues at Mass General have done this, and remarkably, they didn't do it soon enough in my mind, but they finally did. They went to these adults and they said, oh, by the way, when exactly did your disorder start? And when the very structured interviews were done about the onset of the disorder, the majority of the individuals in the adult clinic described a pediatric onset, either under age 12 or in the adolescent years. There was a subset who had an adult onset. We wonder if this is a clue as to, as I said, the different types of bipolar disorder that we may be pulling together for treatment and for clinical care because there are so many similarities. But much like diabetes, you might have a disorder of glucose, but is it adult onset diabetes that needs medication and diet, or is it insulin dependent, which is an autoimmune disorder that needs insulin injections? They're similar but different. Same thing may be true of these bipolar types. In the adult clinic, about 10% of those adults also have a comorbidity with ADHD. Those are my kids grown up maybe, right? And when you look at that subgroup, guess what they look like? They have very early onset, they have chronicity, they have high rates of comorbidity, they have suicide rates are much higher, violence rates are much higher, and they have more legal problems, conduct disorder. This looks like the kids I'm talking about grown up, even though I didn't follow them to that point. Let me spend a few minutes talking about treatments. There's many medicines that have FDA approval now for treating emotional dysregulation in children. Andy talks about how we borrow from neurology for our anticonvulsants, and that we borrow from the schizophrenia researchers for medicines that work for bipolar disorder as well. And in child psychiatry, for long, we've been borrowing from adult knowledge. But now we have a number of studies that show that these medications work down to age 10, sometimes even lower, down to age 6 for symptoms of mania and for mixed states. And the risk-benefit analysis of treating, I have to tell you, has to take into account the risk of not treating. It's easy to be nervous, and I'm nervous too, about side effects of medicines. This medicine causes all of these terrible things. These things can be temporary, these things can be permanent, these things can be life-threatening. It's terrifying writing these prescriptions. It's terrifying getting these prescriptions. But what's more terrifying? Not treating. Not treating is terrifying because there's suicide attempts, there's poor judgment, there's reckless behaviors, there's criminal arrest, abuse and addiction. The terrible outcomes are terrible. And we have some information from our adult studies that delaying treatment can worsen outcomes. So childhood onset and treatment delay were associated with a persistently more adverse course of illness in this very large study of adults with bipolar disorder. Well, the magic treatment algorithm that we have, let me just be transparent here. It's pretty general for pediatric bipolar disorder. Stage 1, start with monotherapy or monotherapy. That means one medicine or one medicine with augmentation. Which medicine? Mood stabilizer. I say dealer's choice. It's up to us as clinicians to read the literature and know which ones are most likely to help, and also then to match that with a particular patient in front of us in terms of their particular symptom sets, symptom characteristics, and their risks for the different side effects. Stage 2, if someone's not doing well, what do we do? Switch to a different agent. It's pretty general. So I wish we had like a real roadmap, like they do for cancer tumors. They do an analysis and they say, you've got this type of glioblastoma. This is the chemotherapy we're going to use for it. We don't have that in psychiatry. And so sometimes you'll have differences among colleagues and clinicians, and it's just reasonable differences because of different practice patterns. But we do know that bipolar disorder is hard to treat. Pediatric bipolar disorder is hard to treat. 50% of adults and adolescents with bipolar disorder, to treat the mania itself, need more than one agent. And that's not even talking about the residual depression and the other comorbid conditions. And the first line of treatment are these second-generation antipsychotics, which really need rebranding because people are frightened of antipsychotic. They're frightened of that word. And when I say people, I mean doctors who prescribe them. My colleagues are nervous about giving children a medicine that's called an antipsychotic. When I describe to parents that psychotic means out of touch with reality, most of the parents look at me and say, yeah, my child's out of touch with reality during these outbursts, doing some of their thinking, doing some of their reckless behaviors. So it makes sense, really, to the individual who's living with it. But it worries people. These are medicines that are used for schizophrenia, which is even a far worse, if you can imagine, condition than bipolar disorder in terms of decline in functioning. Does that mean something about the severity of the disorder? Well, we know this is a severe disorder, and the fact that it responds to this treatment as well is something that we've observed, and it's actually very lucky. Because if you look at this slide, you can see that this is a meta-analysis of all these different pediatric studies. The second-generation antipsychotics outperform the other mood stabilizers that we typically use for bipolar disorder by a good bit. And they work pretty fast. The double-blind, placebo-controlled phase of these studies is usually just 3 weeks because the medicines help within 3-week period. Why don't we use these medicines? Well, tardive dyskinesia is a dreaded potential outcome, but I'm just going to say very quickly, it's not a reason not to use these medicines because it occurs very rarely. It occurs generally after long-term use. So if you have a child who's suffering, you have to weigh that against the misery of not treating, the danger of not treating. Weight gain is a terribly unfortunate side effect, and now most of us who use these medicines, hopefully all of us, have also become endocrinologists, trying to understand how to help people offset the weight gain that occurs when we use these medications. This is 8-week studies. The average age of the kids was about 10. Children who took olanzapine in 2 months gained about 5 kilograms, over 10 pounds on a little kid. That's a very quick and major weight gain. What about the other mood stabilizers? We certainly do use them. We absolutely do, and there's a number of studies to show that they're helpful and they work, and all of us in our clinic have children who are unique responders. Finally, I give them lithium, and it's better than anything they've ever had before, and they're very much better. How do I know at the outset who should get them? I don't. We don't know. And so we don't usually start with these agents, not because we think that the other ones are better tolerated. We start with the other SGAs because the antipsychotics, because the data just shows that they get more kids better more quickly to a greater degree. Do kids get better with these other agents? Yes, adults too. But to start with them, we look at the data and we see this kind of fair response rate, and so we don't tend to go there. The trials were also notable for high drop rates. So all of the medicines have side effects. The side effects in those medicines are often more difficult to tolerate, and they often needed augmentation anyway with an antipsychotic. So you didn't get very far by using them. And then what about the co-occurring conditions? We're just talking about first stabilizing the manic part of the symptom picture, which is what you have to do. That's the most impairing part, and if you don't do that, you can't really stand a chance of helping the depression, the anxiety, the ADHD. We have an array of other agents that we can use. Many of them have been studied mostly in adults and not as much in children, although we do have some data to show the usefulness in children of a number of these different. I'd just say one thing about the pharmacotherapy of the depression and the anxieties. It's very tempting to use one of our standard antidepressants because they're great medicines for depression and anxiety, but they tend to make people, and people include children, with bipolar disorder worse. And so you should copyright your phrase, Andy. They win the battle, but they may lose the war. You can get some temporary improvement, and I see it all the time. Kids come to my clinic. They got better for a few months. What happened? Let's increase the dose of the Prozac, Zoloft, Lexapro, whatever that antidepressant was. And they come to me on high doses of an antidepressant in a terribly agitated state because each time along, there was a window of improvement. Unfortunately, it's not a wise path to take and tends to lead to worsening course and more difficult to treat states. Very quick, few words just about biomarkers. And it's going to be quick because there's no test I can do. There's no brain scan I can do yet. And so people tend to see these biomarker studies and say, give me that brain scan, give my child that brain scan. And we don't use these in clinical practice, unfortunately. But we do have some hope that we can get there, and that's why I wanted to show you a few of these slides. This slide represents some work that we did with proton magnetic resonance spectroscopy. So we've gone way beyond just a brain X-ray. So we now have brain scans and probes that can measure all types of interesting things. This measures biochemical compounds in the brain, and glutamate in particular is one that we think is implicated in this disorder. And we were able in this study to link glutamate in this particular part of the brain, the anterior cingulate cortex, which is a sort of a way station for emotional regulation, with a rating scale, an easy-to-use parent rating scale that helps to indicate levels of emotional dysregulation. My colleague, Dr. Uchida, has a very impressive and interesting study using diffusion tensor imaging, magnetic resonance imaging technique that measures diffusion of water in tissue. So it produces these neural tract images. So it gives us a different way of understanding the structure and functioning of the brain. And she's also been able to link that to our child behavior checklist, that parent rating scale. And how about genetics? Well, we have a lot of hope there too. And this study validates our finding. So this recent 2017, the finding that we had in mid-1990s that bipolar disorder and ADHD tend to co-occur. We used to say it may be a significant genetic subtype. Well, indeed, using these genome-wide association studies with very large groups of numbers of people, we were able to see that early onset bipolar disorder may be caused by different genetics than later onset of the disorder, and it's often combined with ADHD. So I will stop there and happy to take some time to take your questions, and I appreciate all of you for being here, and I'm also so sorry that most of you are here for personal reasons and are struggling with something that we're doing our best to help with. Thank you. Questions? We'll just, yeah? Yes, I see.
Do you see a correlation between bipolar disorder? You want me to start again?
I can repeat. A correlation between bipolar disorder, do we see, and
Other, I don't think this is
oh,
on. And other autoimmune conditions.
the question is about autoimmune conditions.
Yeah.
Mm-hmm.
So be it multiple sclerosis or Parkinson's or fibromyalgia, rheumatoid arthritis.
Yeah, we don't have, in pediatric bipolar disorder, we don't have a lot of data on that. I don't think an adult disorder quite as much either. However, what it's making me think about is a disorder called PANDAS or PANS, pediatric autoimmune neuropsychiatric disorder after strep. Strep infections are common. We all carry antibodies to strep, most of us do, from having it. But there seem to be a subset of kids who may get rheumatic heart disease in an autoimmune way from a simple infection, may have an autoimmune effect in their brain. And those individuals have increasingly been treated with different infectious disease type approaches, antibiotics. I would say a lot of that is still not ready for prime time. We're in the works. We don't know which of those individuals really should go that route with those different treatments, because those treatments all carry potential risks as well. That disorder, though, is usually not characterized by bipolar mood swings. It's more of an anxiety, obsessive-compulsive disorder, tic disorder type of disorder. Yet, many parents who come to me are asking about that, and I wish we had more answers for it. Generally speaking, the kids under my care, I'm not sending them for this kind of PANDAS treatment. And another question behind, yes?
Hi, can you recommend an approach when a patient comes to you and there's a family history of depression and you're not really, we know that bipolar was underdiagnosed. So how do you tease out if you're looking at a kid for depression or bipolar or, yeah?
Yeah, well, welcome to 30 years of my career. I talked a lot about the difference between ADHD and bipolar disorder, but the biggest challenge we have as clinicians is distinguishing unipolar depression from a bipolar mood state. We've got these two big buckets of somebody's got a severe mood disorder. If you have a family history of bipolar disorder, you're still more likely to see depression in those families. And so it very well may be. I show the family history data because as a whole, it helps to validate that we're barking up the right tree in diagnosing these kids. But in any individual office visit, if I see a picture of bipolar disorder in family members, I'm still attending to the fact that this individual may have a unipolar depression and is probably at greater risk for that. However, we're super cautious about asking about not only current symptoms of mania, along with your depression, do you often also have criterion A, criterion B that I showed you, past symptoms of mania, because if you've ever had them in the past, but also as I'm giving an antidepressant, if that's my choice, I'm looking for the development of future symptoms. And I think that that's something that clinicians may not always do as well, number one. And number two, I think they don't think about this developmental picture of mania that involves extreme states of irritability. If they're looking for, I used to say to some child, did you ever have so much energy you stayed up all night and cleaned your house? And the kid, basically, I thought was going to murder me. Like, what are you, an idiot? Why would I do something? Why am I even talking? She was so disdainful. Well, there it was, the grandiosity, the irritability, the rage. And no, she wasn't cleaning the house. She was trashing the house. So you have to think about these other states. Am I looking for somebody who goes out to bars and picks up multiple sexual partners? Well, not at age 6. But can 6-year-olds be hypersexual? Well, yes, and I've heard about those many times, preoccupation with sex, pornography, private parts, touching themselves, touching other people, inappropriate, potty humor, et cetera, et cetera, et cetera. So you have to have these developmental pictures, and that's only as good as your training program that you go to. And increasingly, I'd say our training for this in our child and adolescent programs has improved dramatically. Another question? Yes? Oh, this side, sorry. Go ahead, Andy. Deborah's got it.
I read in the paper that the Alzheimer's Association they were granted $53 million for the study of Alzheimer's. Mm-hmm. I was wondering if any of these studies for other neurological diseases are helpful to your work or the work in mental illness. Hopefully, but I can't name anything right off the top of my head. And I think it's all different things. I mean, I guess you might say to me too, would a study on bone tumors be helpful? Maybe, because we'll learn different techniques for imaging, for genetics, for other things. But in the here and now, like stuff that I could bring to my clinical office the next day, we really need to fund more clinical research and have the clinical researchers partner with the lab researchers better. That's really would be ideal. I mean, it's kind of the thing that Andy's doing with the Dotton Center, and that would be much more helpful. But I guess the short answer to your question is, no, I'm sorry, that's not going to help me. Yeah.
Had a question about on one of the charts that showed how the children would gain weight within 8 weeks. And is there a sense, and I assume it would be outside that study, whether that levels off over a period of time or that's sort of a plateau?
A lot of inter-individual variation. And I wish I had a blood test or a brain scan or something I could do to predict that in particular. Because we also have techniques for starting co-treating early on with things that might offset weight gain. And probably with these second-generation antipsychotics, using something like metformin, which maybe many people have heard of, which is used for adult-onset diabetes. It's becoming increasingly standard of care to just start co-treating with that from the get-go or at the earliest signs of weight gain. Also, it's very difficult to tell some of these kids anything, but healthy diet and exercise, yeah, that would all work too. But indeed, we do try to incorporate that early on with the hopes that it sticks at some point along the way. Those things are all really important. Because the medicines mess up your satiety center. You think you're hungry, but you've already had way too much to eat. And so it's very difficult to not put on this weight. Plus, there seems to be a metabolic change where you just store more weight, middle weight in particular.
We have time for 2 more questions. If you can pass
You mentioned studies that look retrospectively in adults with diagnosed bipolar disorder at onset in childhood. Are there any longitudinal studies that have looked at pediatric bipolar disorder and then what it looks like in adulthood in terms of the percentage where it persists?
Yes. So there's 3 of those longitudinal studies, and one of them is from our site. Another one's this Pittsburgh Course and Outcome of Bipolar Youth, and another one was a St. Louis group. And it's been reported on up into early adulthood. And a lot of people say to me, does the bipolar disorder change? Does it start to look more classic? Like what I call the celebrity Carrie Fisher bipolar disorder? And it doesn't appear to be. Like what I showed you about those adults in the clinic, mixed states, a lot of chronicity, a lot of poor functioning, a lot of violence, a lot of suicidality, a lot of irritability. It seems to be that clinical picture tends to persist into adulthood. I'd say what's most interesting, though, are the individuals who do remit, and what are the magic ingredients, and how can we clone that or get more of that to follow those folks moving up. Longitudinal studies, by the way, are very difficult to get funded, and most of the time the National Institute of Health will maybe fund it for one course, but to follow these kids up into adulthood is difficult to do from a funding standpoint. It's also difficult to do because families move, they don't want to participate, they're very busy, these are stressed individuals and families, so the ones who drop out, I don't know what's gone on with them. Also, the researcher has to keep doing research. And we still are following our cohort of kids, but it's unfortunately gets smaller and smaller with each follow-up because of these dropouts.
And last question.
Hi, I'm just wondering how or if this all manifests differently in boys and girls, and whether or not girls shifting hormonal stuff going on over time affects all this, and also even the ADHD, because there's also a subtype, right, of ADHD without the H, and how that plays into this.
That's a great question. I mean, for a long time, we'd say, gee, what about girls? And the answer would be, who cares? But indeed, unfortunately, and we've done some studies looking specifically at girls versus boys, and what we find is, even though this is a male preponderant disorder, it does seem to present very similarly in girls as well as in boys. ADHD, too, is male preponderant. We wonder if sometimes the male preponderance, especially in ADHD, might be because girls are underdiagnosed. Because if a girl is talkative and chatty and not interested in their schoolwork, they think that's just girl behavior and let it be. And so if they're not very disruptive, they wouldn't necessarily come into the clinic. However, it does appear that there is something about male preponderance. Having a XY is a genetic abnormality. Sorry. One of my female things I get to say. And there are a lot, and boys and children, male children often have more psychiatric problems than females. It does tend to change the distribution throughout age, and we see more depression and mood disorders in women catch up, unfortunately. What do we know about the hormonal interaction? I don't know why we don't know more. It seems like such a no-brainer. I can't tell you how many families say, puberty, what does it do? Menstrual periods, cycling within the month. And we use the same treatments that we use whether that observation is there or not. There are some individuals who are looking at hormonal interventions. Oral contraceptives sometimes help even out women's moods, but sometimes they make depression worse. So we need more work on that. That's a really neglected area. Thank you for asking about it. Thank you, everybody, for your attention.